Welcome to Practical Cardiology Pearls, where complex cardiology is simplified.
In this video, we're going to discuss diuretic resistance. This patient has congestive heart failure. We started oral furosemide, but we're not getting an adequate diuretic response. What could be the reason? First, we should think about bowel edema. Just as patients with heart failure can develop pretibial edema and pulmonary edema, they can also develop bowel edema. Bowel edema, as well as other gastrointestinal conditions, can reduce the absorption of oral furosemide. In this situation, oral furosemide should be switched to intravenous furosemide.
What if we're still not achieving adequate diuresis? What should we do?
About 95% of furosemide is transported to the kidneys bound to plasma albumin, where it exerts its effect. That's why we should check the patient's serum albumin level. If hypoalbuminemia is present, consider starting an albumin infusion.
What if we're still not achieving adequate diuresis? What should we do?
As you know, the nephron contains a sensor called the macula densa. When the macula densa detects a low chloride concentration in the tubular fluid, it activates mechanisms that reduce the diuretic response. That's why we should check the patient's chloride level. If hypochloremia is present, consider administering furosemide in 0.9% normal saline.
What if we're still not achieving adequate diuresis? What should we do?
As you can see, the proximal tubule contains transporters called OAT. Furosemide and all the substances shown in this figure use the same transporter to enter the tubular lumen. If the patient is taking one or more of these medications, they compete with furosemide for the same transporter. As a result, less furosemide reaches its site of action, and the diuretic response may decrease. In this situation, review the patient's medications and disconnect or replace competing drugs whenever possible.
What if we're still not achieving adequate diuresis? What should we do?
If the patient has been taking furosemide for a long time, the response to furosemide may have decreased. As you know, loop diuretics block sodium reabsorption in the thick ascending limb of the loop of Henle. As a result, more sodium reaches the downstream segments of the nephron. Over time, these segments adapt by increasing their capacity to reabsorb sodium. As more sodium is reabsorbed, the diuretic response gradually decreases. In this situation, we can use sequential nephron blockade.
Let's find out what sequential nephron blockade is.
If blocking sodium reabsorption in the loop of Henle with furosemide is not enough to achieve adequate diuresis, we combine it with diuretics that act on other segments of the nephron. This creates a synergistic effect and helps improve diuresis.
If we're still not achieving adequate diuresis, despite intravenous furosemide given as a bolus or continuous continuum, the first step is to combine furosemide with a diuretic that acts on the distal convoluted tubule, such as metolazone or chlorthalidone, and then reassess the patient's response. If adequate diuresis is still not achieved, we can combine furosemide with a diuretic that acts on the proximal tubule, such as acetazolamide, and reassess again. If the patient still does not respond adequately, we can consider adding a diuretic that acts on the collecting duct, such as tolvaptan, depending on the clinical situation. If we're still not achieving adequate diuresis, kidney replacement therapy should be considered. Options include ultrafiltration or peritoneal dialysis, depending on the patient's clinical condition. Now, let's summarize everything step by step. First, think about intestinal edema. If it's present, switch from oral to intravenous furosemide. Second, check the patient's serum albumin. If hypoalbuminemia is present, consider intravenous albumin infusion. Third, check the serum chloride level. If hypochloremia is present, consider arranging furosemide in 0.9% normal saline. Fourth, review the patient's medications. If the patient is taking drugs that compete with furosemide for the OAT transporter, discontinue or replace them whenever possible. Fifth, if we're still not achieving adequate diuresis, perform sequential nephron blockade by combining furosemide with diuretics that act on other segments of the nephron. Finally, if we're still not achieving adequate diuresis despite all these steps, consider kidney replacement therapy, including ultrafiltration or peritoneal dialysis, depending on the patient's clinical condition.
Thanks for watching. Let me know in the comments which cardiology topic you'd like to see next. If you enjoyed this video, please like, subscribe, and share. See you in the next video.